I believe we have everybody who requested to participate. We have let them in. We hope for some more for this webinar on early childhood and how primary care can take care of this particular group. And this is hosted by the European Forum for Primary Care in close collaboration with the Austrian Primary Care Network. And I'm happy that Lisa Meyer, together with me, will facilitate this webinar, which is in fact in a structure of where we want to focus on social deprivation, poverty, and how that relates to health. So taking care of early childhood is crucial if children are raised within families where there are these kind of problems. We have a role to play, I think, and not only the GPs, but in a close collaboration with different professionals. And I hope we will have some discussion on these issues. I think that's all for my introduction, in the sense that some technical issues, this session is recorded. So if you have problems with that, take care of that. And of course, requested to keep your microphone on mute if you are not speaking. And ask your questions in the chat. Don't wait until the end of the presentations, because then we can prepare already some of these questions to be answered by our presenters. I will leave it here for Lisa, who will introduce the two presenters of today, and we'll do some other preparatory work for this nice webinar. Lisa, the floor is yours.
Thank you very much, Diederik. Also, warmly welcome from my side. Just short, the Service Center Primary Care in Austria is centered at the Austrian National Public Health Institute and is funded by the European Union, Next Generation EU. I'm really happy that we can welcome also Sabine Haas. She's a sociologist and has been working in many years at the Austrian National Public Health Institute, in particular on the fundamentals of prevention and health promotion and the strategies for intersectional integration. And as well, Sigrid Mühlhölzl, she's a trained clinical and health psychologist. She has been working for many years as a family supporter and in Vienna and as an employee of the Child Protection Center, Die Möwe. And yeah, I will give the floor after a short questionnaire to Sabine. Before we start, we just wanted to know where are you from which country, and for that we prepared a Slido. I think you should see my screen now. To join it, please scan the QR code, or I will put in the chat the link and the passcode. So the first question is from which country you are. You should see the link to the Slido in the chat. You can click on it, and then the website is coming, and you have to put in the passcode. So already one person is typing. We just wait. And the first one, Austria, Belgium, Slovakia, very nice. And from Austria, Styria, a province. Really excited. Netherlands and Venezuela. Nice combination. Yes. We're just waiting 1-2 minutes. Netherlands again. So a broad European spectrum. Okay. I think we can move on to the second question. If you've heard about the early childhood program before. Okay, but most of the people, yes. And the last question is, there are regulated intervention and programs for early childhood in my country. So if something similar to early childhood programs, okay, yes. No, I'm not sure. So I think the webinar will be a good opportunity to hear about these programs and intervention. And now, Sabine, stage is yours.
Thanks a lot. I'm happy for the opportunity to present about this Austrian program today. I will start with my presentation. There is, since several years, I will explain a bit, an Austrian program for early childhood intervention that is supporting families in need at the community level. The definition of this, of how we call it frühe Hilfen, this early childhood intervention we work with in Austria, is that it's an overall concept of interventions, especially health promotion, prevention, early intervention in early childhood. The focus is on from pregnancy to until 3 years of age, but maximum until school entry. This overall concept is important because the needs and the situation of families in this period of life, they are quite diverse. So in order to meet the specific needs of families, it's important that you have that the families are able to access a lot of different interventions. And this Frühe Hilfen, this Austrian program, provides the basis that families are identified and they get access to this whole variety of different offers for this age. And in order that this is working, the networking is important because all these partners and institutions and organizations have to be organized in a network. The objectives of the Austrian model is to reach and support families in this life period, and especially those who live under burdened life circumstances. The project aims to strengthen the resources and to reduce strains and burdens of families with children. We always look on both sides. We look on the burdens they have, the problems they have, but also the resources they have and they can rely on. It's important to promote and ensure the well-being and the development of children at an early stage. Overall, it's the objective to contribute to a healthy upbringing and very importantly also to promote health and social equity with this program. The main type of intervention are early childhood networks. They are based on regional level. They work a lot with home visiting. It's an outreach program. It's free of charge and it's voluntary for the families to take part in this program. And it aims to provide needs-based supports for families in needs in stressful situations. It's important to systematically and early identify these families and reach them, to promote a secure parent-child bond and a successful parent-child interaction and relationship, to promote the psychosocial well-being and health of the parents' families, because if their well-being is not ensured, it's difficult for them to support their kid in a way that it promotes a good development of the kid, and to strengthen the family in the sense of empowerment. There are defined characteristics for these networks. And the first one is that families are reached actively and systematically. And this requires that all the professionals who are in contact with families, especially the healthcare sector is very important, like primary healthcare, because during pregnancy, around giving birth, and in the first months with a child, almost all of the families contact with the healthcare system. So it's important that all these institutions and professional groups, they know about the program, and they are aware of the needs of families, the kind of families that might need support through the program, and they actively approach them, inform them of the program, and if the family accepts, ensures a direct referral to the program. By now, about half of the families get in contact with the program themselves because it's already well known. But it's important that even families that don't have a lot of information or are very much stressed and therefore are not able themselves to look out for interventions, that they are also reached. Then there is family support, a key element, and Sigrid, who will later explain what this program, how it works in practical ways. She is a family supporter. She works as a family supporter. So this is a continuous and comprehensive support for families, home visits, but also telephone calls in between and so on, over a longer time span. It's important on the one hand to have a relationship element, to build trust, to provide a model for bonding, to engage in a relationship with the families. On the other hand, to refer them also to the specific interventions and services required and that are available by the regional network. As I said before, in order that this is working, networking is very important. So there is a specific role and task of network management within this program. Persons that are in charge to ensure, on one hand, the awareness raising of all the professionals, and other hand, the establishment and maintenance of the regional network. And also this whole support system available in a region is part of the network. The target group are families in need. There is a whole variety of needs the families have. Social burdens like financial distress, social isolation, domestic violence, various mental burdens, characteristics of the parents like minors or single parent or disability, increased needs of the child like multiple births, premature, or some disorders. Very often it's simply at the beginning a strong anxiety or a feeling of being overburdened of the parents. Sometimes it's difficulties in the acceptance or care for the child. And in most cases, several of these burdens are present in combination with lack of compensating resources. And very often it's also at the beginning, when they enter the program, it's often not very clear what kind of support the families would need. So it takes some time to find out and then to refer them to the relevant institutions. The implementation in Austria takes place in a partnership. At a regional level, the provincial governments and their health, social affairs, and child welfare, most of all, and the social insurance providers are cooperating in order to ensure the provision of the intervention at regional level. But overall, in of the federal level, of the social insurance, and of the provincial level. And we at the Austrian Public Health Institute, we are commissioned to the task of the National Center for Early Childhood Interventions in order to support a well-coordinated, efficient, and quality-assured regional implementation We provide training, documentation, networking, guidelines, and so on. And like 1 year ago, about half of Austria was already covered by the program. But at the moment, it's almost all Austrian provinces, because through this European Next Generation EU fund that we spoke before already, also the rollout of the program over all of Austria is financed. And in parallel, there is a negotiation that there will be a sustainable financing for the future. I want to show you a few data to get an impression. The Austrian program started in 2015. There were some pilot projects before, but involving all the provinces started 2015. And until end of last year, more than 10,000 families were reached by the program. And just in the last year, 2,500 families received this longer-term family support, and in addition, 500 short-term supports. You see that it's increasing over the years, except for the year 2020, because at the beginning of the pandemic, there was a bit, the numbers were going down because it was difficult for the hospitals, who are very relevant in order to inform parents about the program, to cooperate in the way they did before and are doing again. Very important for us is that families are reached early, because if families already have burdens, it's a bigger benefit for the kids if you reach them very early and already can take care that there are no negative childhood experiences. So 28% of the families so far, family support started here. And a lot of where the kids are already born are to a maximum of 1 year old. It's very important for us with this program to support health and social equity. And therefore, the data I present here is always important for us to look at. And we can see that compared to the reference value for Austria, that means if we look on, like say, all families in Austria with kids that's up to 3 years old, and the ones that are supported by the program, we see that we reach more mothers that have a low formal school education. We reach more mothers that are born abroad. We reach by far more single parents, and especially regarding risk of poverty, which is about 15% for whole of Austria for the relevant population, but 60% of the families we reach with the program are at risk of poverty. We assess the resources and the burden families at the beginning and at the end of the intervention. Here we can see that the families have multiple resources and burdens when they enter the program. The yellow ones are the resources. We see that housing, level of education, social interaction within the family, and the physical health of the primary caregiver, for example, are relevant resources. The blue ones are the burdens. And here we can see that social network, financial situation of the household, and psychosocial health of the primary caregiver are the most relevant burdens the families have. And mostly one family has several burdens as well as resources, of course. Here we see the change, and the yellow one shows where there was a positive change. And there are quite a lot of different areas where we see a lot of positive change through the intervention. There were various evaluations of the program, and one of them assessed the benefits from the view of families as well as family supporters. And it proved that the program has a positive impact on the health determinants, and it manages to increase the resources families can rely on, as well as reduce the strains and burdens. And for example, financial burden, distress can be reduced, child development or self-esteem perspectives for life future can be improved and increased. Another evaluation looked at key elements for success, and these are the intersectoral cooperation, because the program cooperates, as I said before, with the healthcare sector, with the child welfare sector, with the social sector, and so on. Then the active access and the outreach work, that means a very low threshold approach, is one of the success factors. The relationship work, the combination of the focus on the relationship and trust and the navigator function of the family supporter, the multi-professional teams, and the national-wide coordination. And the evaluation said there is a unique selling point, they called it, of the program compared to other interventions in this area. The needs-based scope of action, the outreach support with its focus on relationship building, the preventive approach with special attention to the strengthening of family resources, and the integration of family support into a network of different services. Because it might be interesting for the communities, there is also e-learning and materials, because the whole medical sector, healthcare sector, is a very central partner of this program. And in order to support the professionals working in this field to cooperate and to address families and to motivate them to take part in the program, we made an e-learning. It's just available in German language for different groups, and also materials for the professionals, but also materials for families that the professional can use in their work with the families. Just to give you, I'm coming to the end, an impression, feedback of the families supported. The families get a feedback form at the end of the intervention, and they send it back to us. And what they that is particularly helpful for them is simply the talks with the family supporter. There is someone they can speak about regarding all the things that concern them, the problems they have, what goes on in their head, and so on. The knowledge that they are not alone, but there is someone who can help them. And also the tips and the advice and the referral to the services. And like a family, they sometimes send very, very personal, emotional words that my fears, worries, and problems have taken seriously. Oh, she always listened well and was like a strong shoulder for me without judging a person. It's also something very important that they don't feel judged. A lot of understanding and compassion, and so on. And before I close, I just want to inform you, for the ones that are in Austria and speak German, there will be a conference in May where a whole day is dedicated to the Austrian program for early childhood intervention. Thanks a lot for your attention. I think we will continue with Sigrid, and I will share her presentation, right?
Okay. Shall we continue immediately? Yeah. Hello, and thank you everyone for listening and being here. I'd like to give you a little bit insight, of my work, my daily business with the families. But first of all, some information about the early childhood intervention in Vienna. And since the beginning of this year, the Frühe Hilfen is implemented by 3 different organizations, which you can see here on this map. They all have a different focus, which is quite good for us to get in contact with the other organizations, because they have a lot of experience in different parts than we have here at the Mühlhölzl, which is most the focus on child protection, violence against children. The Volkshilfe has a main focus on poverty, and the Diakonie has a lot of knowledge concerning migration and flight, and that's something very important for us, and will be interesting in the next years how we can use this knowledge from each other. Okay, you can skip on the next page. Thank you. We have a multi-professional team. We are about now, I think, 13 colleagues, still growing. We have midwives, social workers, psychologists, psychotherapists, pedagogics, and I don't know if there's a correct translation for Frühförderung, for like early support concerning the development of children. We have regular team meetings each week, and we discuss all the families which contacted us during the last week, which are new to us, and find 2 colleagues who will be responsible for one family. While one colleague is the main partner for the family. We also have an external supervisor each month for discussing more complex situations in the families. Yes, and so general conditions were discussed before a little bit. The support is for free, which is very important for many families, and it's voluntary, which is in contrast to child welfare services, which might be something they have to do. And the topics would be like financial distress, like the first child is born, I don't know how to do with it, it's crying, I don't know, what can I do to ease the baby. There are mental burdens, many women dealing with postpartum depression, but also with personal disorders as schizophrenia or something. Premature babies, problems with parent-child interaction, autism, and a lot going on. And as Sabine said, most time it's a mix of several more burdens and not only one. The family contact us via telephone mostly, or via email, and it's one half of the people who contact us on their own, and the other one is this initial contact with network partners like the pediatrician, a nurse, a midwife, the hospital, somebody from the kindergarten, completely different. But the families have to agree that they are going to send the information, the contact details, and the basic information about the family to us. We wouldn't contact them without their knowledge. It's possible to have anonymous counseling. This is really very important for some families because some are really very worried, some are suspicious, some have made like bad experience, troubling experiences with official partners, like, or with child welfare, and they prefer anonymous counseling, which doesn't take place in home visits. We have a bureau where you can have the appointments as well. And the main part are home visits, as already said. I think just one to the home visit, something I like to add, because it's the main part of our work. And I think I can talk about it for hours because it's so special. Concerning for the families, we have a really good insight of the family. When we go there, you have a lot of information in a family. Like there is a dog, which is not so happy when we come around. There might be 5 cats, or we find out that the family likes science fiction, black literature. This is important because it offers a lot to have an insight also in resources which might be there, but also in burdens. And concerning families who have to live in poverty, who don't have a lot of money, it's could be that they are like ashamed when we come to their home. They might have a very small flat. If you can imagine a flat of 35 square meters, we're like sitting on the bed of the family and having the counseling. So it's something not so easy for the families when we come at home. And I always have a lot of respect when they open the door, because I guess it wouldn't be easy for me to let somebody inside my home, a person I don't know, and talking about my problems. Okay, you can skip the next page. And I thought it would be the easiest way to tell you about my work when I'm introducing a family. I chose family A, and they have been assigned by a social worker from another organization. It was also an organization which supports family during pregnancy. And she called us and said, baby Tom came 2 weeks ago. The parents seem to be very overwhelmed with the situation. They don't know how to deal with all the things which are now being their problems as a parents. And they needed support concerning the bureaucratic matters. There is a lot of things to do after the birth of a child, like apply for birth certification and all that stuff. And they had troubles making appointments at a pediatrician, which was necessary because the baby had lost a lot of weight after birth, and they needed to focus on that he doesn't lose too much and that he gains enough weight. The social worker also told us the family resigns quickly because they have made a lot of bad experience with other offices. They haven't been taken seriously. They were sent away very often, and so they say, well, if it doesn't work out, then we won't do it. But a big resource was that the support was very welcome, and the mother was very excited and really appreciated that someone would be coming to her or to their home and trying to support them. Also a huge problem was that the language barrier exists. The family came from, what was it, Western Europe? I don't know exactly. And it was difficult to get in contact or to be sure that everything they said would be understood properly. Okay. Good. The topics within the first 5 months were like feeding problems. Tom had lost a lot of weight. The mother wanted to do breastfeeding, which didn't work out very good, and she was really, really sad because it didn't work out, and wanted to really try it, and yeah, it wasn't like that it went out good. They thought they would need support with the bureaucratic matters. I'm going to talk about it a little bit later, and they had a very difficult financial situations. A few weeks before the found out that the woman was pregnant, the father had lost his job, which was really a cost of crisis. And when the baby was born, there was no job. The mother didn't gain a lot of money before, so it was quite difficult for them. And they had a really small flat and thought they would need a bigger one as the baby was getting older. One big part was also that there was no social network in Austria. They had no family and no friends here, so nobody who could support them, give advices, like a grandmother, a grandfather who would come to their home, maybe do some cooking, support them with the laundry or something, or just be there. And we noticed as well that the mothers seemed to be really overwhelmed when the baby was crying. She had a lot of distress and she didn't know what to do. She started crying too, and thought she would need help concerning this. You can continue. So what did we do in the first 5 months together with the family? We got in contact with the pediatrician, and we accompanied the family to the appointments, which was quite important because they misunderstood many advices from the pediatrician. It was difficult to know what he was to take the advices at home and do the same thing at home. So we went with them, asked also what to do, and we're like, I would say, like a little bit of a translator with the family and the pediatrician, and support them to follow the advices at home. We also organized the midwife at first to support her with the breastfeeding. And she came home and gave advice concerning this topic. It didn't work out, and she had to use formula milk as well, which was really difficult because she was very sad that it didn't work. And for families, especially when there's not a lot of money, it also is a huge financial problem, because formula milk is really, really, really expensive. And which causes a stress as well, because you want to do breastfeeding because you want to do the best for your baby, and you want to do everything to give the child the best food, but it's not possible. So this is the one part, the psychological part that I would say, and the other part is the financial part. So what else did we do? We do support them with all the official channels, like apply for the child care allowance, apply for the residence permit for the baby, check that they got the birth certification. This is important because you need many of these things for further financial support. And also we were thinking with the family about measures to manage the financial situation, like tell them where to get secondhand clothes, tell them where is like a social market. It's a market where people who have a low income can buy groceries and the stuff cheaper. Yeah, and try to find out if there's any more possibility to get this financial situation more easier. And we did a lot of baby watching with the parents, because we noticed that it was difficult for the parents to read the language of the baby, the body language, to understand what signs is the baby showing, what does it mean when is it time, when is the baby open for interaction, when the baby is turning the head, is it like does the baby need a break or needs to rest? And we always took some time of the appointments just to take care and watch the baby and think about, what is this baby showing? What does Tom want to tell us? And as we noticed that the mother got a lot of distress when the baby was crying, we made something like an emergency plan. There have been some Sabine showed us some quite good information we give to the parents. Like when the baby is crying and it's really getting too much for the mother, what would be the steps, like giving the baby to the father, or when the father is not at home. In worst case, putting the baby on a safe place, going outside, having a glass of water and getting out of the situation before it's getting too much and she might be starting to shake the baby. Yeah, topics from the month from 5 months to 1 year. The financial situation was still difficult. They wanted to apply for a bigger flat, and as they got more confident in being in their roles as parents, they wanted to get in contact with other parents and discuss what's going on, meeting other parents, sharing their experience. So it was easier for them to go outside and yeah, got in exchange. And one other topic was they wanted to go to they wanted Tom to go to kindergarten or crèche, which is a group for smaller children. And it was necessary because the mother wanted to start work when Tom was about 1.5 years old. So we had to apply pretty soon. And as we have been in the family for a longer period, we had quite often appointments at the beginning every week, then every 2 weeks, then when the situation changes and gets a little bit more troubling, then again each week. It's important, as Sabine said, that we build of a lot of trust in the family, and so we got to know more details about the personal background. In this family, we found out, or the mother told us after about a half a year, that she had experienced violence in her own childhood, and she noticed that when the baby cries, she was thinking of her own situation, and so it was difficult for her to deal with the memories of her own history and crying, the crying of the baby. And another thing showed up. Tom showed some signs of developmental delay, which the mother or the parents noticed. What did we do with the family? We supported them in the application for a new flat, and we were looking for toddler groups in the district. Maybe here it's important to say that that it's quite expensive to get a ticket for the public transport. So we really had to take care that there were groups in the district, or find maybe some financial support to buy tickets for the public transport. Yeah, we did the registration for the kindergarten, and decided to make an appointment at the family decided to make an appointment at an outpatient clinic for diagnostics and treatment for the developmental delay. What else did we do? We did a lot of counseling concerning the development of children, as it was difficult for the parents to notice when the baby grew older that some things they did were not appropriate. The baby needed something else. They didn't know how to play, what was matching to the situation of the baby. And still, we did a lot of baby watching and reading the body language and the signs. As you can see, these were topics which were ongoing during our family support. Financial situation got better from 1 to 2 years. The family was waiting for a new flat, and appointments were still ongoing. And the mother wanted, or decided that she wanted some counseling or some therapy, as she noticed that she had to deal with the troubles from her past. We can skip on the next page. And sometimes we can't, we don't have like something working. Make everything better. Sometimes we have to deal with it with the family together and be there and just listen to them and deal with it that something can't change or doesn't change immediately. Yes, and still the support concerning finding therapy and counseling concerning the child development. And yeah, this is maybe where I stop. I'd like just to add one more thing. As Sabine said, that self-esteem increases, and we knew that the mother they gave up easily. And I'd like to tell you that I think the baby was Tom was about 2.5 years old. She went to an office and needed some formula, and they wouldn't want to give it to her. And she said, "Well, if you don't give it to me, I'm going to call Teresa and Sigrid. They are my family supporters, and they'll come and they'll manage it." She got that one. She got the formula. I didn't consider myself as somebody to be a threat to anybody else, but it did help the mother to have this presentation and support her, like sitting on her shoulder. And a few weeks later, it wasn't necessary. She didn't need us as a threat. She did it on her own, and she insisted, and she got the information she needed. So yeah, thank you for listening.
Well done, Sigrid. In particularly, of course, in this case, but also in general, I think the work you do looks great, and the bigger picture presented by Sabine made it clear that it is not only at your spot successful, but it is Austrian-wide, where you book a lot of successes. So that's a good thing. There are quite a number of questions, and I have some, so I prefer to continue quickly. A general question, Sabine, to you from Helmut Chovanec about, well, in fact, what is the result of the program in terms of outcome and education and health? So do you have already data on this?
Yeah, we don't have it for the Austrian program. What we did is when we developed the program, we looked on international evidence. And there's a lot of evidence on adverse childhood experiences and positive childhood experiences and toxic stress and so on, health, a life course approach, etc. That shows that this early age is very important for life quality, education, and health later in life. What we have is that the families supported by the program are asked whether they are willing to get contacted again for longer term research. So we are collecting these forms of parents that are willing to participate, and we contact them once a year. So we did do this since a few years now. So once a year, we are getting back to them also to stay in contact, and we ask them. And what they tell us is that, of course, some of the families are facing some problems again. Of course, life is going on, but they feel more able to search for or to access support sooner, and they feel more capable. But it's the program started slowly in 2015, so the time is not long enough yet to really for Austria to prove for Austria that this international result showing that these early childhood interventions have a long-term positive benefit for the kids can be proved now. It will take time.
And Sabine, about what kind of international comparisons you talk, which countries were you refer to?
The studies on adverse childhood experiences, they were first in US, but later also in UK, for example, in Belgium, in different European countries also.
Yeah, it's a pity our UK participants did not show up, I think, because of the time difference. Otherwise, we could have asked some input from the UK representatives. I think this international comparison is interesting, yeah, because there was the question also how much families, but I think your figure you show the figures and they are quite impressive. So that's wonderful. There is another question about the cooperation with the other colleagues, and my specific question is on the collaboration with GPs. We have also an Austrian GP in our audience. Maybe he can react afterwards. But for both of you, is there a good collaboration with the GPs at primary care level, at community level?
From our part of the National Center, it definitely is. It's GPs and pediatricians. It's, I have to say, more difficult with gynecologists. It's very good cooperation with hospitals, with the maternity clinic. But of course, the daily work of GPs and pediatricians, gynecologists, that are in a, how we say it, insurance-based practice makes it sometimes difficult, because they don't feel that they have the time to like spend 20 hours discussing with a family and motivating them. That's therefore we made materials and we did something to support them. But we have a good exchange with on professional levels. And for example, some GPs and pediatricians, they say it's really also a relief for them, because sometimes they feel, okay, this family, they are coming again and again, and I feel they are really not comfortable and they have difficulties, and I keep them in my head when I go home. But if I know I have a program I can refer them to, and they take care of them, it's good. And so all this, like GPs, pediatricians, and so on, they are very relevant because they're in contact with the families. They are able to identify the families, and the families very often trust them a lot. So they are like competent persons. So if they tell them, look, there is some program that might be helpful for you, it means something to the families.
I saw another very interesting question, and that was about hidden communities or closed communities. That's a better word. And maybe Sigrid, you have maybe some experience in that respect, or otherwise Sabine can answer this question. Rudolf Windeschofer mentioned the Chechnya community, and I think that's indeed, and you have more these kind of groups. Do you have experience with those close communities?
We made a study on the Roma community.
Yeah.
And we looked on the Roma community in Burgenland that is there for centuries, and on the migrant Roma communities. And we learned with them what we have to take care of to be better able to access these communities. And for example, for the migrant Roma community, it was important that there is what is not, but it was not clear for them that they're not obliged to accept a home visit. Because sometimes they are coming from countries where home visiting is always something to be controlled by the government, by the authorities. So for them, it was important to be clear that voluntary, that they don't pay. It was important that right at the beginning, we have to get some administrative support as a door opener. And it took some time, some meetings outside of their homes before they build it up the trust, and then they say, are you happy to come home? So it's different. Somebody in the chat asked about rural. It's not just always the closed communities or the hidden ones. Sometimes also in the rural area, it takes more time because people know each other, and they are like, okay, if somebody is coming and the car is standing in front of my door, what might my neighbor think? So there are a lot of we always try to reflect on them and to look at the data and to learn how to approach. But there are still, of course, a lot of challenges.
Yeah, thanks for answering already that question. I had it in my, I wanted to ask you already the relationship urban-rural, but you also now mentioned the stigma, which is, I think, very much around, which was mentioned already a few times. Sigrid, do you have certain ways to work around stigma in that respect?
Yes, I think you have to be patient. It's like thinking step by step, and being transparent with the parents. Yeah.
Okay.
And I think it's always important to tell all the parents that they are not alone with the topics. It's most of or a lot of topics has every parent. Like like the worries, will I be a good parent? What can I do different? What happened in my own family? So I think it's always important to tell them you're not alone.
Yeah. By the way, I didn't ask, and I think you didn't mention, what is your professional background, in fact?
Mine, I'm a psychologist.
You're a psychologist, and that's most of the family supporters, or
no. It's really mixed up. Like we have 2 midwives, we have 3 social workers, so it's not mostly psychology. this is because this is often quite difficult for the parents. I've been with the family. I did support them for about 6 years, and I have always been the midwife. They couldn't deal with it that I'm a psychologist. So they was like, okay, my midwife is coming, even if the child was 6 years old. Yeah.
I was also triggered. Barbara Stulik, would you be able to specify your question? How's the cooperation with health professions? Are there courses as well? So do you mean courses for these health professions to be more more prone to these kind of problems? Is that your question? Okay.
Yes, and I think that Sigrid already the first part of my question, so it would only be the second part of the
So are there courses for health professionals to learn more from this way of working and to be more connected to your program?
Maybe one thing is that there is an input about the program and this need for early childhood interventions and for supporting families in this age that are integrated now in a lot of different educations for a social worker, for a midwife, for and so on. So this is one. So just there are special postgraduate education that is focusing on this early childhood. This is one thing. Then this is this e-learning that I presented, that it's available for medical doctors, for midwives, and for nurses. Everyone can do it, but they have this official registration for it. And the persons, the professionals that start to work in the intervention, in the program, they get an education at the beginning when they enter. So there is a special training program.
Okay, thanks for answering. I have many other questions, but time is running out. At least one more. You were talking about the navigator function, and I'm very keen to learn, how do you decide who is the navigator? Because it will be some of this multi-professional team, I believe, Sigrid. So if you have a family within the multi-professional team, it is decided you are the navigator for this particular family, isn't it?
It depends on the personal resources. How much time do I have in the next weeks? This is one part we decide. So and the other part is concerning the information we got from the first call, which profession would be matching best. But it's also some kind of idea. But as we have a multi-professional team, and I know and I have troubles concerning questions concerning breastfeeding or something, I can ask the midwife as well, or see if somebody in the general network is there to support.
Yeah. I saw that Ernst re-logged in, and I'm very interested if he can speak now, because the GP sees himself, as I'm already coordinating for 15 years the European Forum for Primary Care. He sees himself as the key navigator if it comes to assistance to family, health problems within families. So is it not conflicting sometimes with the role of the GP in this respect?
No, it's not conflicting.
Good.
But it's right what Sabine had said. We have a lot to do, and we work in my office with a multi-professional team, and this is very important to manage such complicated things. What's a real problem is that so many different things we should know and respect in the communication with our patients. And the question asked in the office is not always the problem they have. They say, my child is coughing, but the problem is poverty, and I don't know it. Sometimes it takes time, and we need a lot of work on ourselves to respect the different burdens the families have.
Yeah. So the Michael Marmot agenda, so the social aspects of the hidden social aspects of some many times, health problems showed at the GP practice, and you feel very much supported in your practice by also this program, I believe.
Yes, so it is.
Okay, wonderful. Thanks a lot. I think that's a nice way to end, isn't it? Because it's 5 minutes past our. We said we will end at 1:30. Lisa, anything to add? Did I forget anything very important?
No, I was just putting the link to the website of Early Support Intervention Program in the chat. There's also information in English. So, and there can be found a map where you can see all the networks in Austria, which is very interesting. And yeah.
I thought it was very interesting. Thanks a lot for attending. Sigrid and Sabine in particular for presenting this interesting way of taking care of deprivation in Austria. Thanks a lot and have a good afternoon. Bye-bye.